with your scope exam, is stroboscopy ever, does that ever add anything, or really, you just need to look down there and make sure you're not seeing anything, bad?
Yeah, I would say I mean, as a laryngologist, I love my stroboscopy, right? So I'm like a poster child. I have it on my hoodie, that sort of thing. But the reality of is for most patients, initial stroboscopy is not realistic, right? Like to say that, oh, you need to strobe everyone. Let's, be a little bit realistic here. No, primarily nasolaryngoscopy, distal chip ideally, but even flexible fiber optic is fine for initial diagnosis. I add stroboscopy into my practice when there's things such as, for example, chronic cough, and especially if the patient's older, right? So I'm really looking for that glottic insufficiency. If the primary complaint is something like hoarseness, then of course I want to add stroboscopy if they're coming to see me. But for a lot of these, like for example, globus and stuff, as an initial scope, I think realistically just a plain nasolaryngoscopy is good.
And the findings that we talked about, or that you listed, they are, would you say pretty non-specific? So like could be caused by other things too, or
100%. Yeah. And that's the reason why I don't like saying that this scope proves you have LPR. Because if your patient's coming in and they're like, I've been throat clearing for 2 years, well, of course they're going to have mucus on their vocal folds, right? It's the chicken and the egg, like which one came first, right? So the act of throat clearing itself will produce mucus. The act of chronically coughing will cause pseudosulcus and irritation at the vocal fold level. So a lot of these things can be the result of the symptom itself as opposed to causing the symptom.